Thanks a lot. This is going to be a three-part presentation, followed by a few questions from the panelists. Our goal is to share our learning experience of using open standards and also running the first connectathon based on IHE in Senegal last year. I don't want to take too much time at the beginning of the presentation. Just thanking again, of course, the organizers for the opportunity to present, and also GIZ, BMZ for the financial support that allowed us to do this project. And I will hand over to Babakar to start off the presentation.
Hi, everybody. Thank you for having us. And basically, just to set up the situation, the main challenge in Senegal is that the government has started to invest into a digital project in the health area. And basically, what is happening is you have most the specialists concentrated in the capital, Dakar. And when you have patients that are like in some other region, they have some issues, they will be sent to Dakar to see a specialist, and their medical record will not necessarily be following them. So that's a big issue. And if you have, even in Dakar, you have two different hospitals that are using two different systems. The issue is, how do you share basically the data between those, especially when it comes to lab results, imaging results, and all of those elements that are costly for the patient. And if they have to repeat them once they go to a different hospital, that could be a main concern. Now, in our situation, we are a healthcare IT company, and one of our clients, HMO, which is Hospital Military of Wakam, one of the city in the capital. They have around 250,000 patients and 300 user medical staff. And basically what we did is we had to customize the system to their needs, and it's an ongoing, I would say, challenge to increase the rate of adoption of the system. And one element that we found is they always compare, the paper system with the electronic system to see what are the advantages of using the electronic system. What we found out is, if you can give them some features that they cannot have with the paper, that's a win situation. And one of them is to have the ability to consolidate the complete medical record of a patient that they have to deal with. And for that, you just have to be able to collect that data from different, basically, software system. And that's where the interoperability, need comes to place. And as a company, we had discussions with other software companies that are in our field to see how can we come up with a way that we can basically share the medical record between our system. And we found out that it was really a tough task, because first, what standard are we going to use? And all the time to develop those type of thing. And if we have a third or fourth, basically provider, how are we going to accommodate that? That's when we got the invitation from Kaikai, which was really a welcome invitation to join their project to develop IHE in Senegal, and then give us the interoperability environment. And that was a commitment from us to be able to follow through the project that I would say lasted about a year, where we had several training sessions, and then we had the technical part where we had to commit some staff to go through environment, the model, and do the coding, do the testing, and then after that, everything culminated with the mini-connectathon to just really see that our systems are behaving properly in that environment. Now, in terms of solution, what are the benefits for the medical staff? Definitely, having access to the full record of a patient, regardless of where the document is originating, it's a big plus, because that give them a way to capitalize on that information, not to repeat labs, not to repeat imaging tests and all of those type of things, and then also to have a better picture of the medical condition of the patient. For the patient, usually when they go from hospital to hospital, they have to carry their medical record with them, just to make sure that if they have some chronic disease or some special condition, that the doctor is aware of it. And seeing that the doctor will have access to their full record, I think will just put them at ease to know that they will get much better care. And for the health ministry, the cost of healthcare, it's one of the biggest challenge when it comes to the population to have access to those services. So if you have means to share their medical record with the different providers, that would be a big way to reduce the cost of access to those healthcare. And also it will give them also means to comprehend what are the different medical conditions, medical difficulties that the population is going through. Now, for our business, it makes it much more appealing when it comes to delivering some products to our clients, because that would be like a real big advantage to people that are always, lingering into the paper system. Now, in terms of perspective, we see that the IHE is an environment that has to be, basically shared by different parties. It's not just us as a software provider that with our commitment that we can make it happen. It includes the government, because it's a platform that has to be somehow national in order to be valuable. And then we have also the doctors, medical staff, and also the patient. So basically, it's a major effort that needs to be taken by different parties, and it needs to be organized, I would say, in order to be effective. Now, why IHE for Senegal? Basically, the government since 2018 has been really pushing to digitalize the health system, and this is really to improve care and also to reduce costs. Basically, as been stipulated by the World Health Organization, and we have also the health system challenge, because basically the concentration of the specialists in Dakar, access to some specialists and everything, being able to share the information is something that is really valuable in terms of continuity of care. And the private sector, the solutions that we are deploying to give like an added value to those solutions, you need to have the IHE interoperable system, and also the methodology, because that the IHE is using is something that is very solid and widespread, and it's a standard that is to the top level. So which means that when you invest in it, you will make sure that it will give you some good rewards.
Thank you so much, Babakar, for providing this overview and context of the relevance in Senegal, and also your experience with the HMO has been invaluable. As a reminder also, so Babakar is a representative of one of 3 HIS providers that we worked with in the project, and I will now give you a bit of an overview. Basically, the project is carried mainly by Visuapps, that's a leader in IHE at a national scale, based out of Europe and Austria, which has a lot of experience in Connectathon participations, and Abdallah will be able to provide some of his perspective in the presentation. In this project, they were responsible for providing their experience with the IHE work, with the standards, the solutions, the testing process, and also some of the connections to the IHE Europe community. We as Kaikai, we are a consulting business based in Dakar with projects in the West African region. And our role in this project was to provide the bridge to the Senegalese context, the drive discussions with the different stakeholders, and also identify and organize the process of working with the Senegalese private sector. And on the right side, you see the 3 HIS providers that were selected to work with, who were AeHIN, Passion Pro, and Medicine. And all of this was made possible by funding, which was private sector promotion funding from the Invest for Jobs program of GIZ and the BMZ and the German government, through an association which is called African German Health Association. So just to also, as a step back, what is IHE? So it's a community of over 300 medical equipment and software suppliers that got together well, quite a while ago, 1997, to promote data exchange in radiology, and then evolved through different parts of health data exchanges. And basically, it's an association that promotes interoperability, and they identify existing standards, work on improving standards, and also define profiles, use cases for when to use these particular standards. And parts of the methodology is also the rigorous testing process to verify the compliance with tenders, to the extent that now even the European Union recognizes in their public tenders the compatibility or the conformity according to the connectathons, that solutions are conform to the standards. And on the right side, you see an example for a connectathon. So those are events that are happening every year in different places, and where suppliers get together and over a few days, with several months sometimes of preparation, do rigorous testing according to the different profiles that IHE manages, in order to identify like errors or gaps in the implementations. And then all the test results are documented and are available also to reference, as I said, in tenders. So as Babakar mentioned, so we see a lot of different advantages of using interoperability, and particularly the IHE methodology. And I want to particularly highlight the principles of the no avoiding vendor lock-in, because as governments are investing into interoperable solutions, it's based on being based on open standards, like the IHE, allows governments to select solutions that can be exchanged at a future point. And that really allows also hospitals or other healthcare institutions to be reassured then that they are not investing into a solution that they will be depending on for 10 years, 15 years, and also like keeping competition makes innovation happen. So you are sure that you're getting better quality for your money. And it also allows for the creation of markets of solutions. So currently, a lot of the solutions are focused on North America and Europe and to a certain extent Asia. But also what the standards allow, if documentation and all the standards are publicly available, as is the case with IHE, anyone can integrate those standards into the existing solutions or create new solutions to work on some parts of exchanging health data. And of course, the last part is data protection, because we are dealing with medical data, with personal data, especially on patient records and medicine, highly sensitive information. And so also part of the IHE methodology is a strong emphasis on data protection and data security. So the overall goal of the project was to demonstrate the feasibility of exchanging medical data in Senegal using the IHE standards and methodology. And traditionally, there's been a lot of work in other countries to work on based on feasibility studies. And we decided very early on that this was a project where we wanted to focus on demonstrating end results and making things happen that are tangible and that are working. And that's why it's a bit different than some other projects. And now we are spending also time disseminating the results of what we did. And we'll talk about some of the perspectives later in this presentation. So the other objectives was to train a selection of Senegalese HIS providers in IHE and the different parts of the methodology, and also to explore some of the regulatory and institutional steps required to set up a national IHE infrastructure. Some of those things will need to also be picked up by other partners. As Babakar said, this is heavy lifting that cannot be done just by one project or one program. And the ultimate goal is to set up a Senegalese IHE community. So I will now hand over to Abdallah to describe the phase of implementations of the project.
Thanks, Nils. Thanks for AeHIN for the invitation, and thanks for the audience for their presence. So we start with the first phase of this project, and which was the most delicate one, and was to look for the appropriate partners and the stakeholders and the mapping for their respective roles in this project. Kaikai was really instrumental in this phase, where they helped us to create the working groups dealing with the different aspects of the project, from the steering to the data protection. So the creation of this steering committee and the discussion that we had with the different members brought up the challenges that these stakeholders that we are talking about face in their daily handling of the patient records, as it was mentioned by Babakar earlier. The representatives include the Ministry of Health with its different departments, the national hosting provider, SENEM, the Data Protection Agency, the hospitals, obviously, and the private IT sector association, OPTIC. So the main preparatory task was to identify 3 local firms providing IT services to care providers. We defined some selection criteria to identify those companies, including the size of the hospitals where their solutions are deployed and the technical expertise of their teams. Given that the cooperation with these companies would include the sharing of some internal intellectual property material, We signed NDAs and the support agreements for sure, because it involves also training of these companies. The selected companies were AeHIN, Patient Pro, and Medsen. The project started by a training session of 3 days, where an overview of IHE was presented to the decision makers and the technicians, and 2 days were dedicated to the technical training that covers managing the patient demographic and documents, intra and inter-community, and included also how the security and privacy are handled by IHE. So after the training days, individual sessions were with his providers were organized in order to identify the integration profile, the IHE integration profiles that are relevant for their use cases. So the idea was to discuss with his providers, see how they use their software solution in their daily business in the hospitals, and identify the connection point where they can involve and integrate the integration profiles that we identified. After those sessions are done, we agreed on the profiles and the standards that to be used to meet both the functional requirements that they face in their daily business and the technological sustainability, because also that's an investment for the companies and they need to be sure that this is an investment for the future. Those we chose the standard FIRE for almost all the profiles. So after more than 3 months of intensive work and integration, the providers were ready to test with the reference system, which was provided by Visuapps. We avoided to use the Gazelle testing tool, which is used by all the connectathons, because we have a small number of participants. We have only three participants and a reference system. Instead, we defined a structure on a Google Drive where we stored the executed tests. These tests are based on the Gazelle official tests. So we are following somehow the same approach as the official connectathon. We tried as much as we can to have a similar approach and to use similar tests, the same tests almost. We contracted also an external renowned monitor to verify the test. We didn't want to verify the test ourselves, because during these training session, some relationship was created between us and his providers. So we contracted an external monitor. This monitor is an author of many IHE integration profiles and a cybersecurity specialist. So we performed the test for the profile that we have defined, and which are, sorry, Nils, can you go back? Which are time client for consistent time, secure application for ATNA, authorization client for IUA, patient identity source for PIX-M, patient demographic consumer for PDQ-M, document source for MHD, and document consumer for MHD. So once we finished testing with 100% success rate, we disseminated the results to the decision makers to highlight the importance of such step in order to reach the international level and also to achieve the technological sustainability. So testing was not, in fact, the last step of this project, because we aim also at using the implementations to exchange production data to prove the added value of such approach. The idea is to integrate 3 hospitals that you see in this diagram: Hospital Hôpital Militaire de Ouakam, Clinique Privée Hôpital Roi Baudouin, to exchange the production data that comes from those hospitals, and where also the solution of the providers are deployed via the reference system provided by Visuapps, while using the profiles that we implemented during the training phase. So the whole infrastructure is hosted in the Senegalese national web hosting provider, Senum. So the Senegalese data would remain in Senegal, and we are currently coordinating with the data protection agency to get the necessary approvals to proceed with this phase, because in order to store Senegalese data, we need to have approvals from the data protection agency to proceed. In addition, we are trying to disseminate these activities and the results that we have achieved in order to encourage other countries in Africa and all over the world also to follow suit. Thank you, Nils. Can proceed if you want.
Thank you so much. And thanks, Abdallah, for describing the project in more detail. And I really want to highlight the value of this collaboration that we had not only between Kaikai and Visuapps, but also really building strong relationships with the different HIT providers and some of the stakeholders for the project. So that brings me to some of the lessons learned, and the first one is a good fit because it's really putting the emphasis about stakeholder engagement, and not only with the Ministry of Health, but also like other stakeholders like Ministry of ICT. And this was also underestimated at the beginning of the project on our side. It's never just a technical project. Even if you put the emphasis on interoperability and data standards, if you don't do certain kind of alignment and engagement, it's going to create blocks later on. And so we really also tried to have an open and collaborative approach, and I think that paid off. So, for example, the trainings that Abdallah mentioned, we opened them to other partners that have activities in Senegal, like Path Digital Square, Tony Blair Institute, and really try to also keep in touch with other projects, because this is a demonstration project. It's a feasibility demonstration, and there's a lot of pieces that need to be put in place in order to go to scale. And that cannot be just one project that carries that. As I mentioned earlier, the focus was really to demonstrate results and not just concepts. And I think that was also really appreciated by a lot of stakeholders in the project and outside of the project. And we put some emphasis on also communication about the project. We're dealing with quite technical topics here, but also sometimes it's about finding those stories that we can use. Like Babakar mentioned, for example, the fact that sometimes a patient's family, especially outside of Dakar, has to travel in order to pick up results, and that the costs and complexities that this brings are really stories that can be highlighted. And in fact, that communication paid off in a way, and I will speak to that on the next slide. One of the principles was also, as Abdallah mentioned, to reuse as much as possible from the proven methodology, but sometimes we also needed to adapt and to make the tools a little bit simpler for the scale of the project. I think the collaboration between Kaikai and Visuapps really also made that possible. And as a last lessons learned, we also have to be open about the limitations. I mean, certain things took longer than expected to make happen, and also there is a lot of things that we have not been able to figure out in this process. For example, how to integrate with other health programs like the HMIS platforms that are in use in Senegal. So in terms of perspectives, so currently we're really like working on the capitalization of the results by other projects in Senegal. There's funding coming in from the World Bank, which will have also like tremendous opportunities for the digital health ecosystem in Senegal, and other players that are also working on supporting the governance in digital health. And so we're making sure that we are disseminating the work that we are doing so that it can be built on. We're also like thinking about future additions in order to integrate better with some of the other existing health programs. I mentioned the HMIS with the DHIS2 platform that's being used in Senegal, and also to work on the right incentives for other healthcare providers to adopt interoperable solutions. One of the success stories, I think, of this project is that through the communication that happened after the Connectathon, IHE Europe reached out, and we are currently looking at facilitating the participation of the Senegalese providers at the next IHE Connectathon in Trieste for the IHE Europe community, and where they will not only be testing towards a reference system, but where they would be participating as a regular participant to test the solution against solutions that are being used on the European and global e-health market. So that's really exciting for us, and we're looking forward to this collaborations. And of course, like I want to close this slide also by mentioning that we really also need to look at how can interoperability and the role of leveraging the regional and local private sector in West Africa specifically be strengthened by having an IHE community that's active in this region. And this is really something that we're interested in having conversations with others about, because we think that the time where multiple countries are making investments into this sector is really now to make sure that we can leverage on the experiences, but also make sure that the private sector can play a strong role within a framework that ensures quality and sustainability. So we're coming to the final session of the presentation before opening the floor to questions from you and as the audience. We prepared a few questions to also like leverage on Abdallah's and Babakar's role in the project. So I wanted to ask you, Abdallah, to describe a little bit, based on your experience you have working in this field for many years in also regions of the world. How was your experience working with his providers from Senegal?
Thanks, Nils, for the question. As I mentioned in my presentation, in the very beginning, we defined some minimum requirements for the software provider to be selected. And among those criteria are the technical expertise of their team, of their respective team. So we can somehow talk the same language. This helped a lot in the very beginning, since from the very first day, we were able to exchange regarding complex matters and solve eventually the very first challenges that we encountered. To be honest, I didn't see any difference between the exchanges that I had in Europe and North America and the ones that I had with the Senegalese partners. IHE somehow defines the interfaces for all of us, and it's for us to find the appropriate tools to implement those interfaces. Same applies for the identification of the integration profiles. The partners in Senegal brought their needs and their use cases within the healthcare facilities, and it was for us throughout our long experience in the domain to identify the appropriate integration profiles to use. It's nothing new for us, since we help our customers and partners all over the world with the same needs. But at some point, it will be the opposite direction, since the Senegalese partners will learn and will be more experienced than us in some areas also, and they will be able to share their experience with us. So to summarize, I didn't see any difference.
Thanks, Abdallah. And now to you, Babakar. How was your experience being one of his providers working in the project, and what did the participation mean for your business?
So basically what I was saying is that this was a very welcome opportunity for our company, because we are providing health information system to hospitals, medical clinics, and private sectors, and so on. And we are facing also competition from local providers, but also from international providers. And this capability of having a tool to interact with all the systems
it's very much needed, and it's also demanded by our prospect clients and our clients. And knowing that this is a standard that we cannot emulate just by ourselves, it requires the involvement of government agencies, and having also the technical level to handle basically all the programming and all the development that is needed to put together, a system. So having the assistance, technical assistance, so we didn't have to do that much hard work to go and then trying to look for codes and so on. So that was an excellent thing. And then also to have some organization engaging the government into this project is also something really, really important, because we as healthcare solution providers, if we approach the government, the question will be, do you have the experience? Do you know exactly what you're doing? So all of those were already answered by Visuapps, which definitely has, the experience and know-how to implement this type of environment at the country level. So it's a win-win situation for us, because we participate in a project that really improve our product and also give us perspective when it comes to the whole region, not only Senegal, because you have also the neighboring countries that will come to Senegal for healthcare needs. And if we can just basically extend our service to those countries, having a tool that really meet the high standards, that's an excellent thing.
Thank you, Babakar. And now maybe back to you, Abdallah, and the same question will go to Babakar after. Where do you see the biggest obstacles for leveraging the IHE experience in sub-Saharan Africa or Senegal, based on the work that happened in the last 2 years, and what needs to happen next?
I think we saw it together, Nils, in this project, that the problem is not the technicalities. The technicalities are the least of our problems somehow. The main challenge is to engage with the politicians, with the decision makers, and make the case of interoperability and get the support to go forward with these initiatives. I would say also what happens next, it's the same as the USA and Europe, which is being able to have a secure, trusted, national, interoperable exchange in every country in sub-Saharan Africa, and then try to have an exchange between these networks, as it is the case for USA with NWN and in Europe with eHealth data space. This will unlock new possibilities for the patients and for the governments, as we saw with the new law that passed recently with the AI in Europe, that will be also used in the eHealth DS project. So that's the idea, starting from the very bottom, from the regions to the national levels, and then try to integrate also in the sub-region with an exchange that will allow people and patients to cross the border to get care while not having to take their records in paper, but simply move to and go to the next country without with their records being stored in the cloud or in being exchanged between the countries via the net.
Thanks, Abdallah. And from your perspective, Babakar?
I think that Abdallah has summarized all the main challenges that we have, and I totally agree with him when he says that it's really dealing with government policies. How do you navigate through all of the requirements, and then how do you convince these managers to adopt this technology, because it's a must-have in terms of digital healthcare. And then on the other side, to really give a meaning to this environment, we need to be able to develop products that won't just take advantage of that interoperability. Basically, if you have mobile apps and that will take advantage of that. I think that having the patients putting their weight in the necessity of having this type of system will really kind of like force the hand of the government to really basically adopt this type of technology, because it's, you can say it's like a kind of like a business. You need to have the demand in order to have like the offer. So if the demand is getting high because you have some products that take advantage of interoperability to give to patients a freedom to carry their medical record wherever they see fit, then you will have more and more patients that will like to have the same type of product, and the government will not have much choice but to implement this environment.
Well, thank you, Babakar, and this concludes the prepared part of the presentation. So I see there are some questions in the chat, and I'll hand over to you, Cha. I want to thank everyone again for the opportunity to present, and for the audience already for participating.
Yes, thank you very much for the presentation and for kickstarting the discussion, Sir Nils, Sir Babakar, and Sir Abdallah. To all our participants, if you still have questions, please feel free to enter them in the Q&A box or in the chat box, and we'll try to answer them in the time remaining. In the meantime, please allow me to read the questions already sent in our chat box. The first one is from Dr. Alvin Marcelo, one of our directors at AeHIN. So the first one is an external reviewer or monitor needed at the outset, or can they come in later? What's a good time for them to participate?
If I may need to answer this question. So we chose an external monitor because we didn't want to influence our relationship with his providers to influence the outcome of the testing process. The monitor intervened only during the mini-connectathon week. So yeah, the choice was done like 2 weeks before the mini-connectathon. So the monitor was not involved in the training process. He was involved only in the verification process, where we shared with him the tests that we would execute, the processes, and he verified the test during the connectathon week, the mini-connectathon week.
Yes, thanks, Sir Abdallah. I think Dr. Alvin also has a follow-up question to that, like how did you select the tests?
It's easy. So the idea is that we selected the integration profiles based on the use cases defined with his providers. Based on that, we went to Gazelle and we checked all the tests provided by Gazelle for those integration profiles and for the actors that are implemented by his providers, and we executed those tests, nothing more. So Gazelle was our reference somehow.
Thank you, Sir Abdallah. Our next message is from Engineer Derek Ritz. So much capability with only 8 tests. His questions are, what document types did you exchange? And did the participants all adopt a similar content profile like IPS?
Yeah, that's a good question. So the idea was very simple. Go from the easiest profile to the most hard one. So exchanging patient data, feeding a patient, first querying for the patient, submitting a document, securing this whole exchange with the appropriate certificates and secure connection, then adding a token to that transaction, and also in adding the appropriate audits to those transactions. And so I suppose you understood what kind of profiles I am talking about. PICS-M, PDQ-M, MHD, IOA, ATNA. And in the very end, when we knew that his providers really understood what we are talking about regarding the MHD agnostic, document agnostic nature, we defined the tests for MHD, which consisted in two types of documents, two sets of metadata, one for JPEG document and one for PDF document. We didn't go further with CDA IPS because it's more complex, but the idea would be to also implement IPS in the future, but we didn't reach CDA at that point.
Thank you, Sir Abdallah. Our next question reads, all the three devs were verified. Was it difficult for them or was it only a matter of time?
The three devs were different, in fact, and our role was not only to explain and to train them on IHE matters, but also to help them to implement in the matters of code. So Babakar, he's here, and he uses C#, for example, in his software. We have two others who are using Java. And this is the small difficulty that we had in order to somehow go from one coding language to another. This is the only difficulty that we had, but except that, everybody was cooperative and we tried our best and they tried really their best to help also with this project.
Thank you, Sir Abdallah. There was a question also sent through the Q&A box. It's from Dr. Ayomi. How was the infrastructure management plan? For example, the network along with the data security.
Okay, so till now, it's only testing. That's what we did during the mini-connectathon. For the infrastructure, that's what I said earlier. We chose to host the data for the onboarding phase, where we will showcase and show that the infrastructure really works. We chose to host the data in the national web hosting provider, Senum. So it's for them to host the VMs, and it's for us to provide the software. But IHE also defines what I mentioned earlier, the profiles, the ATNA profile, which secures how the data is exchanged between different partners.
Thank you, Sir Abdallah. Our next question is from Engineer Derek Fitz again. Are there ways IHE Europe or IHE International can assist in helping launch new IHE deployment committees in Africa? I will be happy to help in this if I can.
That's a political question somehow. It's not a technical question. Nils, I'll let you answer this question if you want.
Yeah, I will try. So first of all, yes, I think this is definitely something that there is a potential for a lot of people to get together and to create momentum and ride the momentum in other places. It's like it will take some efforts from different angles. Of course, the IHE Europe and IHE International community can very much provide an example and a case. And we also have to make sure that the differences in context, the differences in culture, and sometimes also politics are taken into account. What is already a good factor here is that the IHE methodology is not prescriptive in a way. It doesn't shape your infrastructure. So the decisions of how to implement it and also modifications to make to the standards to localize are also already to a certain level built into the methodology, and very much willing to continue a discussion on this and see how can we combine different communities that are working on this. We've been also in touch with OpenHIE during the project, with also the New Africa Digital Networks Initiative from Africa CDC. So there's a lot of pieces that I think the puzzle is being slowly built, and it will hopefully create a beautiful image at some point.
Yes, thank you, Sir Nils. I think we're at the top of the hour, but we have one question left. I hope we can answer this. It's from Dr. Daniel Lead. As governance arose as a critical bottleneck, it would be great to create a pitch or business case to present such interoperability projects to decision makers, including not only technicalities but problems being solved, impact, benefits, support from international organizations like the WHO and the World Bank, and even risks. So the question is, do you know if there is something like this being outlined to be shared and enhanced?
So I'll again try to answer on this, and I fully agree with the statement. Obviously, we are private businesses, both Visuapps, ourselves, and also the HIS providers. Of course, we've done our best in this project to leverage the communication opportunities, but I think there's always more that can be done, and to also highlight the stories of the users, because that's what in the end matters. It's not whether the systems are talking to each other, it's whether the health impacts and also the savings that we're talking about in time and in better care are actually being delivered. So I do think that there is a need for documentation and dissemination, and to pass those messages along also to the right instances where they need to be heard.
Yes, thank you, Sir Nils. I think that wraps up our open forum. Before we officially close our webinar, I'd like to call on our director, Dr. Alvin Marcelo.
Thank you, Cha. Nils, thank you very much. Abdallah, Babakar. When I met Nils the first time in Washington, D.C. last year, I was so excited about the experience he shared about this Connectathon, which we want to do more often right now in Asia. And so I invited him, and then he invited Abdallah, and now I get to see Babakar also. Impressive work on the what you've done. I hope we can replicate. I hope this is not the end, of the Connectathon. This is Connectathon happening in Africa. Our Sri Lankan friends, led by Dr. Chaminda, had their own Connectathon 2-3 days ago. We will plan to have Connectathons in the Philippines, Thailand. If we get together and exchange ideas, techniques, and like the social aspects of connecting people together, I think we can do a lot of good work in our own respective countries and across our borders. And I'm really happy to finally have this session. We've been planning to have this session since January. And thank you, Babakar. Thank you, Abdallah. And thank you, Nils, for your time. And thank you for everyone in the call. I cannot name everyone, but you know who you are.
All right. Thank you so much, everyone.
Thank you. Nils, we'll get in touch.
Thank you so much, Alvin and AeHIN. Thank you, Cha, for helping the organization.
Thank you, everyone. Good night, Peter, Derek,
you.
Maxime,
Bye-bye.
Daniel, Dr. Tep, Dr. Binji. Good night, everyone. Take care.